Good morning, ladies and gentlemen. Thank you, Victor, for your nice introduction. I really don't know if you always say the truth, but you are charming, and I like this very much. Okay, yes. The title is a bit difficult, but it was given to me by Ben Raphael, so I will try to handle this problem and try to find an answer for you. You know, for the start of a pregnancy, we need a uterus with a receptive endometrium and a good embryo quality. This is very important. This is a condition to achieve a pregnancy. We know today that morphological criteria are very important to assess the quality of an embryo. Here you see on the left side, a 4-cell stage, very good looking, equal blastomeres embryo who has an implantation rate of about 30%. And on the other side, on the right side, you can see an irregular cleaved embryo with an estimated implantation rate of less than 5%. So it is easy by relative simple criteria under the microscope to assess the implantation rate of our embryos. And there are some experimental methods like assisted hatching or blastocyst culture and pre-implantation screening. We just discussed this in another room, the pro and con of PGS. I think the answer is still not there. We have to wait for new randomized prospective studies with new techniques. So the question also is the blastocyst culture better than to transfer the embryo on day 3? And this was first presented already in '98 by Richard Gardner, and he could show a high pregnancy and implantation rate per embryo with the transfer of a blastocyst. Of course, this was not a randomized study, so the answer was not given exactly. But now we have meta-analysis. This is a procedure to answer these kind of difficult questions, to put together many studies, randomized prospective studies in this way, blastocyst versus the transfer on day 2 or 3. And as you can see, the pregnancy rate with the blastocyst transfer was significantly better. Of course, this was mainly due to these 2 studies from Papanikolaou from the Brussels group. And I think he could show that especially the selection of patients for the blastocyst stage transfer is very important. So we can say that the blastocyst transfer seems to give us a better implantation rate in comparison to the cleavage stage embryo on day 2 or 3. What about the uterus? There are many different procedures to assess the quality and the implantation potential of a uterus. You can do a hysteroscopy or an ultrasound. This is always a first measure, and a laparoscopy if necessary. And there are different problems from the uterus side which we discussed today with you, and I mainly will concentrate on the place of the myomectomy. When does it make sense? Where is the advantage to remove, in special cases, to remove the myoma? We know today that in about 60% of our patients in a reproductive stage and age, they have fibroma. Of course, not all these fibroma make difficulties for implantation, but we know that about 10% are associated with infertility, and in 3% of our patients, this is the only cause of infertility. So we have to select the patients where we can do something. I think you know this picture from the Natta book with a different location and size of a fibroma. Of course, these subdural fibroma, they don't make a problem. You can remove them or not. They will not influence the implantation rate. However, if you have submucous fibroma or intramural fibroma, depends on the size, this can influence the implantation potential of the uterus, and you have to remove this fibroma. Hello? For example, in this case, you see a submucous fibroma, 2, and you can remove them easily by hysteroscopy with coagulation and improve the uterine cavity for another IVF procedure. Important, if you ask for the influence of these fibroma, is of course the location and the size of the fibroids, which can influence the infertility problem. And mainly submucosal and intramural fibroids with cavity distortion, they can influence influence the implantation rate. And especially when these intramural or submucosal fibroma have a size of more than 3 to 5 centimeters. And we know from this publication by Somigliani from Italy that the implantation failure is 33 to 60% because of this fibroma, and also a decrease in the clinical pregnancy rate of 30 to 60%. And we know that we can improve the live birth rate after myomectomy, submucosal or intramural fibroma, when there is a special size. We can improve the live birth rate from 21 to 10%, and especially submucosal, but also intramural fibroids. This is from a publication of Levy from 2012. And also the pregnancy outcome can be influenced, of course, by fibroma. The miscarriage rate with fibroma is much higher, 15%, than without fibroma, 7.5%. And also the pregnancy outcome, that means the mode of delivery, shows that with fibroma you have a much higher cesarean section rate than without myoma. And we also know that the preterm delivery rate and abnormal placentation is much higher with fibroma, especially big fibroma. However, from this study of Surrey, he checked the influence of myoma removal or not removal after and IVF, and as you can see, the yellow bar is hysteroscopic myomectomy, and the blue one is myomectomy by laparoscopy, and the brown one is no removal of the fibroma. And you can see that the influence on the ongoing pregnancy rate and the biochemical pregnancy rate and also the implantation rate is not so very severe. So you have to select the patients who will take profit of this operation. There's also an interesting review and also a meta-analysis from Sukara from 2010, and he could show patients less than 37 years undergoing IVF treatment with myoma or after removal of the myoma, and these myoma were non-cavity distorting intramural fibroids. And you can see that with the operation there is a slight significant improvement of the pregnancy rate in comparison to no treatment. This could also be shown in the same study of Sankara for the first IVF treatment cycle, a slight increase of the pregnancy rate with the operation in this non-cavity distorting intramural fibroids. And also for all IVF patients, there was an improvement of the pregnancy rate in this meta-analysis with the operation. There are also alternative methods besides the operation to remove fibroma. You can use the uterine artery embolization or also the high-intensity focus ultrasound. However, the question is, how can this influence the fertility rate? And up to now, it is not recommended because of safety reasons to use this method in patients who still want to get pregnant. And future studies have to be done with these new methods just to prove if this is safe. There are also medical treatments, and you can see these here. You can try to change the size of the uterus by the use of GnRH agonists. However, they will come again most of the times after you stop the agonist therapy. And you can also use, and we heard this yesterday by the excellent lecture of Philippe Bouchard, can use gestrogens or SERMs to modulate the effect of estrogens. And these two new methods seem to be very effective to influence the size of the fibroma, and maybe then you can remove them. So just to conclude, submucosal fibroma and intramural distorting the uterine cavity should be removed before assisted reproduction because they have a strong influence on the success of the IVF procedure. If you have intramural fibroids without uterine cavity distortion and involvement, it's a risk and benefit analysis which is necessary, and you should decide this together with the patient on an individual basis. Of course, the size of the fibroma is very important. And subserosal myoma do not affect implantation if the size is not too high and if the intramural part is not too big. Thank you very much.